Well, hi everyone. I'm Chloe Santa Maria. I am one of the PGY5s. And today my grand rounds is called Good Vibes Only, the art and science of professional voice care and injury prevention. As most of you know that I'm really excited about, passionate about, singing and music's always been really important to me. So what I wanted to start off doing is just telling you a little bit about myself and how I kind of got into this and a little bit about my context, I guess. So, in the immortal words of Simply Red, or actually originally Harold Melvin and the Blue Notes, if you don't know me by now, you will never, 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 never know me. No, you won't. Okay, so I think most of you do know pretty well, actually. I think I'm a bit of an open book, but if you've ever thought or wondered to yourself, why is she the way that she is, or why does she do or say the things that she does, I thought some context might be useful. So I originally hail from Perth in Western Australia. Australia is surprisingly huge. It has the same, or almost the same landmass as the US. WA, or Western Australia, is the largest state in the country, and Perth is our capital city. And despite all of this enormous landmass, the population is tiny. So we have about 1 million square miles of land and about 2.8 million people. Another way of putting that is we are about 6.5 times the size of California, but 1/14 the population. Some fun facts for you. Australia is obviously a beautiful country. It's known for its laid-back lifestyle, its beautiful beaches. Fun fact one, there are over 10,000 beaches in Australia, so if you were to visit one every single day, it would take you 27 years to do so. More context for me and why I am the way I am. In 2005, security guards in Canberra's Parliament House were banned from calling people mate by the Department of Parliamentary Services because they thought it would offend visitors. The ban lasted a total of 24 hours due to complete public outrage. Fun fact 2, a big televised political debate in 2010 was postponed and rescheduled due to conflicts with the finale of the reality TV show MasterChef. Didn't want to make that too difficult for people. And more fun facts, the term "oh yeah nah" is obviously the polar opposite of "oh nah yeah." Okay, lastly, this is where I am from. So there is a small island off Perth, called Rottnest, and this is the only place in the whole world where you can find quokkas. They are nicknamed the happiest animal in the world for obvious reason. The island got its name because Dutch sailors were sailing by and they misidentified these beautiful little fairy creatures for very large rats. They decided not to stop because they thought it was a rot nest or a rat nest island and kept sailing. Silly for them though, because it's actually a complete and utter paradise. Okay, so moving on, I went to University of Western Australia for my undergraduate degree and my medical school, and I graduated in 2010. Also hailing from UWA is one of our Prime Ministers, Bob Hawke. He was our 23rd Prime Minister, or our President equivalent, between 1983 and 1991. He's known for a number of things. He's a fantastic person. He was responsible for introducing universal healthcare in 1984 in the form of Medicare. He also introduced superannuation for every worker in Australia. But definitely his most memorable contribution to Australian history and sort of our heritage is during his time as a Rhodes Scholar in Oxford, where he went on to get the Guinness World Record for drinking 1.5 litres of beer in 11 seconds. Quite the feat, and that's our Prime Minister, so representing. All right. So after graduating, I went to Sir Charles Gairdner Hospital. This is the hospital where I did my internship, and sort of my early years of surgical residency. I spent a lot of time with this very lovely gentleman, Professor Peter Friedland. He was the head of otolaryngology at Charlie's. He was on the first paper that I ever wrote, and he helped me navigate sort of junior residency and otolaryngology applications. He's really interested in voice, and he has a voice clinic which I was involved with during my time. And I also spent some time with him back on my elective fairly recently, so that's us together only a few months ago. He also just happens to be Nelson Mandela's his personal otolaryngologist for almost 10 years, and we're currently working on a project together looking at acoustic analysis of Nelson Mandela's voice and changes over time. Ultimately, over the next 8 years, I would go back and forth between Perth and California 3 times. I did 5 years of surgical residency, 2 of them in otolaryngology. I did a Master's of Public Health at Cal, and I had 2 babies before starting residency here at Stanford in 2018. I was obviously always interested in singing, but my interest for laryngology and voice care really strengthened during my time here at Stanford. Just before we go, I'm going to be showing a few laryngoscopies during my talk, and they are identifiable information, but everyone has consented to being in my talk. Okay, so my interest in vocal injury really started to peak in my second year here at Stanford. So during my second year, I developed a really bad URI around Christmas time, and I got laryngitis, and I had some really impressive dysphonia. At the time, my love for singing was greater than my understanding of vocal hygiene, and I would still briefly sing along to songs on the radio and singing with my kids. As a result, it didn't really get any better, and at one point, Dr. Sung pulled me aside and said, "Chloe, I think we should scope you at some point. You sound like you have a T3 lesion, and it's not seeming to go away." I couldn't agree more. It wasn't sounding very good, and eventually, with some voice rest, I did get a scope, and this is me. So this is me on the improve, and I was diagnosed with vocal nodules. I was given sort of a strict plan for voice rest, and things definitely started to improve. But this quote by Miguel de Cervantes, who wrote Don Quixote, "He who sings scares away his woes." Mostly true, but not always true, I found. For me, it's just started something a little bit annoying. But in general, things improved and life returned back to normal. So fast forward to April of 2022, so last year, and I get another URI 2 weeks before World Voice Day. This time, though, I was a lot more keen, a lot more understanding, and I was quickly to stop any kind of vocal use, and I went on a course of steroids, and all with the hopes of trying to get back to sing and perform on World Voice Day. Alas, it was not to be. This is Dr. Drenzo scoping me, and we will go from there. Maybe I have to go on this one.
There you go. All right. Coca-Cola. Baby bottle. A baby bottle. Just breathe.
You turn it down. We just want to work out how we can turn that down. It's quite unpleasantly loud in here.
On the bottom,
On the bottom, right, yeah.
If you turn the cursor, so as if you were going to start it,
Yes.
and you look to the bottom right,
Yes.
it might work.
Yeah,
So
let's try
go
that.
like that. Let's try that.
Oh.
Oh no. Okay. We go to almost nothing.
Yeah.
It's a little better, but it's still extremely loud.
But just on the...
Yeah, sure.
Yeah. Don't know. You got two baby nodules. Well, actually...
For a week. Okay, so I'm going to skip ahead. But basically, I've heard all of you very loudly my audible disappointment at a recurrence of some lesions.
You look a little bit maybe bigger on the right than on the left.
It's that was on like post-URI, like...
Do you want to go... Honestly, you probably might have had them there before a little bit. So you swallow. Actually, look. There you go. All right. Chin up again. All right.
My high register is like non-existent
Yeah,
now.
that makes sense with how that looks. All right. Let's say E. Good. E-he, E-he, E-he.
E-he, E-he, E-he.
He-he-he.
He-he-he.
Woo.
Woo.
E and then sniff. E. Do you remember having an asymmetry?
No.
A few more.
That was pretty symmetric, eh?
You're pulling on the left more than on the right. E. That makes sense. Yeah, and it's fatiguing.
So there's a strobe attached to that. But basically, ultimately what I was diagnosed with was some vocal polyps and a vocal paresis. And definitely my vocal polyps have improved. They're probably still there a little bit, but they're a lot better. And annoyingly, the paresis has persisted. Again, okay, so I guess that kind of got me interested in thinking about how we can, what can we do differently? How can we prevent vocal injury? What are good techniques, what are bad techniques? And how could I kind of avoid this altogether? But I guess before we start talking about the art behind caring for the voice user, I thought we should talk a little bit about the art itself. So when we think about human voice and voice production, we think of a mechanism that's made up of 4 different components, mainly. A generator, a resonator, a vibrator, and the articulators. So our generator is our lungs, our diaphragm, our core muscles. We're talking about breath support, which is really fundamental for singing. It's related to all body posturing, alignment, and all of the kind of movements that allow for an open, kind of free throat to allow you to sing without any kind of vocal stress and low effort. We do a lot of breath exercises and support exercises with singing, and all of that connecting these muscles and having everything coming down from below, so kind of ensuring that all of this is stable, open, and relaxed, and that all of it's coming down from your core. There's a lot to do with skillful inhalation and exhalation and alignment, open back, chest posturing, and all that. We'll go to the next one. The resonators are the nasal cavity, the sinuses, all of those, the pharynx, all the muscles, parapharyngeal muscles, and they are the things that contribute to this unique quality, tone, depth that we hear with a certain sound produced. And then our vibrators, which I skipped, obviously our vocal folds, and we're going to be talking about that obviously all throughout this. And then our articulators are our lips, teeth, tongue. They all kind of contribute, the buccal mucosa, all of the movements inside the mouth that really add a wonderful quality to the voice and to singing. And when I think of articulation, I think of singers like Julie Andrews, who are obviously wonderful singers, but the control of the articulatory sort of apparatus is unique and extraordinary. Okay, so a little bit of sort of more basic terminology. Talk about pitch. So pitch is obviously the frequency of a sound, and when your vocal folds vibrate together, they make a certain frequency, and this can either be high or low or somewhere on the spectrum. Modal pitch is a comfortable pitch in speaking register and in singing. And it's where our voice has a central tendency for vibration, which kind of ends up being its fundamental frequency. So singers will call this their chest voice. This is where they kind of comfortably, they'll have either an octave or 2 octaves that are just really where they sort of sit comfortably. And when we do a pitch glide, we aim to capture as much as we can a full range of a singer's range. So low to high, high to low. So this is a little short video from one of our wonderful singers in our music school. I'll play it twice. Slide, high to low, low to high, one of each. Beautiful. Okay, so just nice to see, but I guess some things I wanted to comment so that you could we have a look again with this in mind. So first thing, she has an open mouth, or kind of embouchure shape to her mouth opening. The range and quality of the voice is obviously wonderful. There is a changing shape of the glottis that we all know characteristically. When we go up in pitch, things will kind of lengthen. There'll be a tilt to the glottis. But if you stare at her neck, there is little to no movement of the actual laryngeal structures in her neck. So it's not going up or down. Everything is staying nice and stable. High to low, low to high, one of each. Beautiful. Glide. Okay, then we go fast forward to this other professional voice user. This is Tom. He is a classically trained Shakespearean actor, and he's got many, many years of performing under his belt. He's also a professional vocal yoga instructor. He works here at Stanford and he gives classes on improving breath control, vocal control, enunciation, articulation, public speaking. But what he isn't a classically trained singer. And so I'm going to show you what he does when he does a pitch glide, and you can kind of see the differences. Come over. I have to keep switching my mouse over, which is annoying. No, it lets me do it over here. Okay. Wow, that's a range. Nicely done. Alright, so what you see is he uses all of his muscles to get his pitch to go up, which is a really common thing. Everything moves up, everything tenses, and then when it goes down, everything drops back down again. And for singing, that is not ideal because you want it to be as effortless as possible. You want to have all of the fine control on the other muscles and not your neck. Okay, so tone, or the timbre of the pitch. So when we talk about tone, we are talking about that unique color to a voice, that sort of either warm, dark, rich, or even shrill quality to a voice. And that is determined by predominantly our resonator. So all of these sort of things are supraglottic tract, all of these sort of parts of the vocal tract. This amount of space, the tension, the coordination. So having all of these tight really affects your ability to make a nice tonal quality to your voice. Emotions can also affect your resonator and your tone. And it's sort of this balance between this breath coordination, alignment, and also articulation. So when I think of tone, I think of this, one of the people I think of is this wonderful singer. She actually has some vocal pathology, which you can see on her scope, but her tone is beautiful. And what you will notice also is when she sings, her jaw is loose and open, and she has this kind of really relaxed lower jaw, lower face. This is frustrating. Okay.
Now you say you're lonely. You cry the whole night through. Well, you can cry me a river. Cry me a river. I cried a river over you. Now you say you're sorry for being so untrue. Well, you can cry me a river, cry me a river. I cried a river over you.
So she obviously has some mid-fold lesions of some description. On her strobe, they were quite firm. She is in the process of having an evaluation in the operating room, but her tone is amazing, and I could bathe in that voice. Okay, so I thought that would be a nice segue to talk a little bit about phonotrauma. There's a lot more to talk about singing, and we'll jump a bit back and forth. But when we talk about phonotrauma, we are talking about injury to the vocal folds that happen as a result of vibration between the two of them, and that can be in the setting of reflux, of inflammation, reflux, URI, laryngitis, or in the setting of overuse, so misuse, overdoing of the vocal apparatus, or in the case of probably me, a bit of both. So the anatomy is obviously not new to anybody, but just because it is relevant to what we're talking about, we have a vibratory layer of the vocal fold, which is our vocal cover, so our epithelium and our SLP, and then we have our vocal body. So we have our intermediate and deep lamina propria, which is our vocal ligament, and our vocalis. And the development of benign vocal fold lesions, when they commonly arise, they will if they affect the vocal cover, will interrupt that mucosal wave and that pliability of the vocal fold. And then you'll get abnormal vibratory patterns. They're typically located in the mid part of the vocal fold where the shearing forces are greatest. If they're bilateral, there is often a dominant-sided lesion and a reactive-sided lesion on the contralateral side. Symptoms will typically be dysphonia, fatigue, increased vocal effort, and then these are a list of the most common lesions we see where there are loads and loads and loads. And there isn't tons of good evidence or tons of good science in this area, but studies suspect that fibrous reactive lesions are more likely to be persistent, and polypoid lesions are more likely to recur. And lesions that are sort of have a gradual transition between normal and abnormal, and they're kind of on that vocal fold edge, they are more likely to resolve. Most common risk factors are vocal overuse and misuse. Other things that have been found to maybe play a role is there's been increased expression of pepsin found in excised vocal fold polyps. However, when you give PPIs to patients with polyps, it doesn't improve or change their voice outcomes. So just a few of these lesions fairly briefly. We'll talk about polyps. So this is obviously what I had. I had one very small one and a little reactive lesion on the other side. They are usually unilateral with a little, more than bilateral. They will often have a thin overlying mucosa. They may have a little associated hemorrhage or some dilated tortuous vessels, like a varices. And they'll give you a sort of breathy dysphonia because there's an hourglass shape on strobe. In general, performers are more likely to get lesions than non-performers, and that's probably because they're using their voice more. There is also a heightened worry in performers that they're going to have a vocal fold lesion. Some papers will indicate that as many as 64-65% of dysphonia in singers will actually have some kind of phonotromic lesion, and it being fairly less than that in the general public. However, I've read studies that have been a lot less than that, but it just kind of gives you an idea of the difference. Nodules, they tend to be fairly symmetric. They're bilateral. They are definitely a sort of contact pressure, sort of vibration related injury. There is some evidence that vocal fold vibration increases intravascular pressure, and then that can cause an inflammatory cascade. And so they'll get this kind of edematous lesions. And so strobe again will be this hourglass shape with a breathy dysphonia. Vascular lesions, there aren't many we're going to talk about just because there are so many different types, but this one, we can either be a varice, an ectasia, or hemangioma. They're very, very rare. They will typically be on the superior aspect of the vocal fold, and if there is associated hemorrhage, it'll be a very sort of stiff strobe exam. Okay, reactive lesion, so that little star on the vocal fold, that is the reactive lesion. The other side is the primary pathology. So it's a contralateral lesion in response to a primary lesion. Again, it will be on the mid portion of the vocal fold usually. Okay, last one of these. Sulcus vocalis is something a little bit different, but all in the same sort of family. It is a lesion where there is an absorption or loss of the superficial lamina propria, which is obviously completely needed for normal vibration. It'll often be in response to some kind of primary pathology, and they'll get a deep furrow and a very stiff vocal fold that doesn't want to vibrate. They'll also often have some degree of glottal insufficiency, and so that is something that needs to be treated separately. But overall, this is a really challenging thing to manage. Okay, ultimately though, prevention is probably the best thing. So good vocal hygiene, good vocal habits. So not overusing your voice, not misusing your voice, keeping hydrated, avoiding caffeine, avoiding alcohol, things that dehydrate you, being in a nice, healthy environment, avoid inhaled irritants like smoking, vaping, marijuana, not being in smoky bars, and triggers for other things. So avoiding triggers for reflux, managing your postnasal drip. And then if you are a singer, practice good singing habits. So warm up, cool down, have good posture, alignment, supported breathing, don't use unnecessary accessory muscles. Okay, so care of the professional voice. There are lots of different facets to this, but the voice team is really 4 people. There is the performer, there is the laryngologist, there is a speech and language pathologist that specializes in voice, ideally, and then there is a singing teacher. And it's really important for all 4 of you to be on the same page and to be involved in the team. And I think it's important not to make the singing teacher feel alienated, and also important to make sure that the singing teacher is giving good, helpful advice. When you're seeing a patient for the first time, it's really important to build trust and rapport, and so you do that by showing some kind of relationship, some kind of common ground, I guess. When you take a history, you need to work out what the complaints and concerns for the singer actually are. The singers will be really in tune with their voice, what they can do, what their current limitation is, and they'll be able to tell you what's different usually. They may use like musical jargon. They may say, well, there's this break in my passaggio, which for a lot of people that wouldn't mean anything, and to me a couple of years ago that wouldn't have meant anything either. And so it's nice if you can have some kind of common language that you can help to relate with your patients with. What else? Taking history. Okay, so when we do history, it really is taking a history the same for any voice patient. All of the normal things, onset, acuity, triggers. Does it return to normal if they don't use it? And that's good to know because that will rule out any large structural problem. Ask about their singing style. Ask what your voice does that you don't like it doing right now, or ask what it doesn't do that it used to do that you want it to do again. What are their current demands? What are they currently needing their voice for? Are they touring? Are they about to go on a musical theatre play tour or something like that? All of these things are really important. Knowing their general health, past medical history, all of that is a given. And a physical exam, doing the full physical exam obviously beyond the scope for this, but important to assess the quality of the voice, which you can do with your ears. So is it raspy, rough? That may reflect something wrong with the mucosal wave. Is it breathy? That may reflect something wrong with an impaired glottal closure. Is there a change in the resonance? That may reflect something in their supraglottic tract, or something different about their resonator. And then if they have a reduced range or their pitch is altered, it may be because their vocal folds are stiff, or even something like SLN pathology. Video stroboscopy is obviously imperative. Rigid, there are 2 types of ways of doing that. You can do a rigid strobe, or you can do a flexible. Rigid are probably a little bit better for magnification, but both of you will get you a diagnosis fairly frequently. Genres of music and singing styles. So this is just the tip of the iceberg. There are so many different things that can be done, but interestingly, it probably is true that the way and style of singing that someone does plays a role in the sorts of vocal lesions that they present with. So in general, studies have found country, folk, gospel, jazz, and musical theatre to be singing styles that are more likely to give you some kind of vocal lesion. Interestingly, classical singing, which is probably the most rigorous, challenging singing, they don't always present with, or they're not more likely necessarily to present with vocal lesions. I don't know if that's to do with sort of very sophisticated training and high degree of training. When they do get lesions, they are more likely to be sort of chronic low-grade pseudocystic lesions. That's just interesting to note. Gospel singers, which are these, obviously very typically emphatic singers, they're more likely to get polyps, and potentially that's related to these, very emphatic, acutely injurious events that occur with singing. Musical theatre is a very challenging singing style, also increased risk of vocal lesions, and part of that is probably to do with the bouncing around that they're required to do. So they will go these, high-intensity lyrical singing to acting to more sort of Broadway show styles. It's kind of bouncing around back and forth, and it's often very high intensity. And so that puts tons of stress on the vocal apparatus. When we're looking at classifying a voice, there's a number of different ways we can do it, and a few different qualities that we look for. So vocal range is the most common classic way we do it. We look at the span of pitches that someone can sing, and typically the range will be their full span, but the comfortable range will be their tessitura. So that's where they can sing really comfortably in their chest voice. When we can then kind of sub-classify, so we can base it on sub-characteristics, so things like the degree of vibrato, agility, intensity, and timbre. But the most common way we do it is by doing the sort of tessitura pitch range. So for females, going high to low, we have soprano, mezzo-soprano, alto. There are way more than this, but these are kind of the bulk of the mix. And for males, tenor, baritone, bass. So C4 is middle C, and so it'll be 2 octaves above that they can comfortably sing. But classically, they can sing a lot more than that. So the average non-singer can sing around 1 octave to 1.5 octaves, or with 12 semitones in each octave. But a trained singer can comfortably sing at least 2.5, often more. Passaggio is the Italian word for passage, and it's looking at the transition between different parts of the register, and that's quite audible. So when someone goes from chest voice to head voice, or falsetto, there is often an audible either a break or a shift in the way they sound. And if someone was to do a full ascending glissando, which is a full pitch glide, there'll be multiple transitions, and so that will be from like a pulse voice to modal or chest voice to head or falsetto voice, and then in some women, whistle tones. And interestingly, for some reason, this is also a vulnerable area in people's register. So not only does it often have a bit of a break, but if there's an issue with someone's vocal apparatus and they're not singing as well, this would be one of the first places that it's noticeable. Okay, so more on classical on singing. This is obviously this is a classical singer from our music school. He is a baritone or a baritone tenor, and I will say that briefly, and we can talk about it.
Wo die Rosa hier blüht, wo Reben Lorbeer sich schlingen, wo das Urteilchen lockt.
Right, so obviously beautiful voice, beautiful vibrato, which as you noticed is actually a lot of the pharyngeal musculature was what was contributing to that. And that can then affect these little flickering movements in the larynx. So moving on to some not classical styles of singing. I'm going to play this and then we'll talk about it. This is wonderful. Whatever you want.
Try one sound, I don't know what.
Yeah, let's do it. I think beatboxing is amazing. It's so fascinating. It's got some similarities with typical sort of singing, but so many differences. So it's this form of singing that utilizes percussive sounds, vocal mimicry, and obviously tons of it is to do with the resonator and the articulators. They're making noises as they inhale and exhale, which is obviously not what we do with normal singing, and I just think it's absolutely wonderful. One thing with him, obviously you see tons of neck movement. He was trying to do a lot of vocal things that we could see, because most of it happens in the mouth, but you got a sense that all of this is shifting up and down, and that his bass tongue is moving, his pharynx is moving, yeah. Okay, so, the question comes up infrequently, when is the time, if ever, to intervene and recommend that a performer shouldn't perform? So obviously it's not something that we would ever take lightly. It can have these huge repercussions for a performer, short and long term. So, number of different scenarios. Say they can perform, they perform really badly, and it doesn't go well for them, and then they potentially further injure themselves. Or you say they can't perform, so they don't, and they lose their current performing role, and they get the reputation of being unreliable. Obviously, they're extremes, but they're potential. Really, there are only two scenarios where you really should say, do not sing. Number one is a vocal fold hemorrhage. In that instance, you just say, don't do it. Don't do it for 6 weeks. The other one being a vocal fold tear, and that is a lot shorter downtime, so maybe even after a few days you might be okay, but definitely not in the sort of real acute term. There's obviously relative voice rest for for majority of phonotraumatic lesions, and so we always recommend that. One thing that can be done in someone who it has to perform or really wants to perform, you can do things like changing the melody, so bringing it down half an octave or an octave while you're practicing to reduce the stress. You can mark the rehearsals, which means that you can say half sing or really lightly sing when you're not actually performing, taking the melody down, and then just tell singers not to push it, because they often do want to push it even in rehearsals. Oh, sorry, skipped there. Okay, so balancing the desire for a performer to perform and the risk for further injury can be really hard. Often we will give people a short course of steroids, sort of 5 to 7 days, prednisone, methylpred, and that has really, really good short-term effects. That obviously has to be balanced with the long-term sequelae, but for short courses I think it is fine for the most part. We will always recommend voice therapy and voice rest, at least relative voice rest. The voice therapy exercises that we typically will recommend are ones that help with vocal fold tissue mobilization, and they help produce low impact vocal fold vibrations. And so they are things like semi-occlusive vocal tract and resonant humming or straw phonation. And so what that practically means is, as an example, you put a small straw in your mouth and you sing, an octave as much as you can, the notes in an octave, and you have a semi-occlusive vocal tract. So you are, and that is it's causing a protected vocal fold vibration. And what also that mobilization does is that produces anti-inflammatory mediators, which is really helpful. So, microlaryngeal surgery and beyond. For most of these lesions, all of these lesions really, for the most part, surgery is not the first thing we do. It is the last thing we do. We do all the other things first. But if someone has a lesion that has very poor response to all of our conservative stuff that we've offered already, and they have a significant functional impairment, then we can consider surgery. Obviously, again, as I've said 4,000 times tonight, we don't take said intervention lightly, so surgery we don't take lightly either. There's a lot less room for error when it's someone's livelihood, career, identity. Not that we would ever say that the voice is important for everyone, it's very important for everybody, but it's probably slightly higher stakes. There's also the risk that you can make things worse, of course, which is partly why we get a little stressed about it. Okay, so principles of phone microsurgery are pretty much the same for all voice users, of course, but we want to be conservative. So the exact surgery that is offered will be dependent on the lesion in the individual, but they will have a bit of a similar flavor, as you'll see. So these are just a few examples. The first one is a microflap for a subepithelial cyst. The second one is a microflap for a fibrous mass. The third one is just a submucosal excision of a nodule. And then the fourth one is draping back a microflap for a polyp excision and then just removing any redundant mucosa. So that's the surgery part. Looking beyond is kind of looking at newer treatments, so emerging therapies and phonotrauma. This first one is just kind of cute. It's not really that scientific, but the English National Opera Group, supported by the NHS, have started offering 6-week operatic breathing and vocal lessons to help people with COVID who have got like dyspnea post-COVID. And while it's not exactly scientific, people are reporting really good outcomes with their voice and with their breathing. And so that's just lovely. Then this from out of Japan had a really interesting model to look at the effects of a strong antioxidant. So I'm definitely going to say this wrong, astaxanthin, but it's a strong antioxidant, and they wanted to see whether that would help with phonotrauma. And what they did was they got a number of healthy non-singers, gave them really high vocal loading tasks, and then did an absolute battery of testing. So they did all the acoustic analysis, they did strobe exams, they did aerodynamic assessments, vocal fatigue index questionnaires, all sorts of things. And then they prescribed them with a month of high-dose antioxidants, and they did exactly the same thing again. So they did really high vocal loading exercises, and then they retested them. And what they found was that they did a lot better with a month of antioxidants beforehand. PRP is definitely an emerging therapy that different centers are starting to do studies using. And so platelet-rich plasma, or PRP, platelets are we definitely know they have a role in wound healing. And when we inject them into a vocal fold, or at least into a vocal fold of a rat that's got some scarring, it definitely accelerates the epithelialization probably by inducing endothelial growth factor. And so the thought is it may actually prevent scar formation. When we compare that to dexamethasone, PRP does better as well, which is interesting. Other things people are trying are photodynamic therapy. So typically photodynamic therapy is used to treat skin lesions. And so what it does is it induces cell death through reactive oxygen species. And they've been doing that with lesions of the vocal folds in rats. And what they're finding is that it is improving wound healing and remodeling and vocal fold thickness, and things like hyaluronic acid, actually. So it's higher post-treatment and less collagen types 1 and 3. Growth factors definitely are showing promise for improved wound healing. I know my husband loves growth factors in wound healing. So here's the ones that we've been looking at for vocal folds are hepatocyte, growth factor, and basic fibroblast growth factor, and they are showing some promise, again, in a rat model. And then lastly, just some novel regeneration strategies. So they're looking at extracellular matrix sort of derived biomaterials, so creating synthetic polymer scaffolds for novel treatments for vocal fold repair, particularly for things like vocal fold scarring and fibrosis where there's a loss of SLP. And there are all my references. And before I finish completely, a couple of little thank yous. First person is Beth Terenza. Thank you for everything. My mentor in life in many different facets, my research mentor, my just general life mentor. Thank you for being a wonderful human being and being incredibly supportive. Kwang Sun for being, again, an incredible mentor and a support and advocate throughout my last 5 years. Dr. Dan Rose, thank you for taking out your frustrations on Dr. Ayub and not me. He's not going to notice, and I really appreciate that. And the last person is my sweet husband, who is currently asleep in a luxury spa in Africa. Much love. You are the best support. That aside, you are the best support. And thank you for putting me first and prioritizing me every single day. Thank you. All right, that's it. We've got some time for questions if anyone has any.
I have Zoom open, so if anything comes up. Just great talk, Chloe.
Thanks.
So I'll ask a question. And this is a hard question to answer, and I don't actually know maybe
Well, thank you in advance, but continue.
what the right answer is. So in this care of the professional voice, right, you talked about it being a team, just as any voice care is, but I think that you made a really important point about bringing in the singing teacher, right, as part of this also. So I was wondering, and maybe again, this is something that you're not sure of yet or you continue to do, is kind of, how do you kind of broach this intersection between voice habilitation, as in learning like voice singing technique in an injured singer versus kind of voice rehabilitation, right? Because, we have these things and they could be very complementary. So
yeah, it's a good question. It's a good question.
So maybe repeat the question. Well, I think they can hear these on actually.
Yeah,
That's
we can
good.
go on.
Yeah, that's good.
I don't know. I would say that that the vast majority of my voice rehabilitation was with my singing teacher. So she thought that, she was terrified by the whole situation and made it very upset. Because things like that. And then she was like, all right, we need to do, so she was actually really instrumental. She's like, right, we need to get some singing straws. And we're going to be doing this, and we're going to be doing these octaves, and we're not going to go above this for at least 2 months. And so she actually was really an integral part of my rehabilitation. I don't know how you do that. I guess you include the singing teacher as part of the plan, and it's a team thing. And you say, listen, you get to encourage what you would recommend in your speech and language session, and try and continue on in your singing lessons. I think.
Yeah.
Yeah. What's that, man? Chance?
Well, great talk. Congratulations. Chief talk is no small task. I actually have a couple professional singers I've seen in my clinic, but obviously they're not seeing me for voice issues.
Yeah.
They do need sinus surgery, and
Yeah.
people ask how any kind of sinonasal surgery would affect their voice quality.
Totally.
I don't know how to answer them.
Yeah, it's really
But how
yeah.
the sinonasal cavity affects voice resonance.
Yeah, so it does. It does affect resonance. We just don't know how much. We don't know how much for each person. So, a lot of people are really worried about getting even their septum changed. I think septum's pretty fine. But, I think that it's a question I don't know the answer to. But I do know that obviously all of that contributes very much. That beatboxer that I played, he had the largest turbinates. I couldn't actually get a scope. It was so hard. And I was like, should I do anything about that? I said, probably not. I said, if you feel bad and you want to, then that's something. But if you don't notice it, I would leave it alone. Yeah, it's a good question. I don't know exactly how much it contributes, but it does.
This is a little bit related. So the larynx is only one, contributes to one of the 4 parts that make up the voice. It's the vibrator, right? You talked about these 3 other parts.
Mm-hmm.
What is the role of the laryngologist treating professional voice users in treating the other parts?
Yeah, good question.
The muscles.
Well, I think that it's a team thing, right? So the laryngologist, they know the vocal fold part the best, and probably can give the best advice about that specific part. But then Beth Lorenzo would be better at teaching people how to use, to not get muscle tension, or to do semi-fluid vocal tract exercise, or do voice therapy. All of that is going to be affecting this region rather than the glottis part. So I think it's a team, and you overlap in which areas you specialize in.
To the point that was made earlier about resonating after different types of surgery that is not on the larynx, I remember growing up there was a lot of mythology about having adenoids removed and having your voice change, at least from the high school singer perspective, which is interesting because we know that adenoids tend to sort of regress by that age. But the big sort of talk within the music scene that I was in was that if you need a tonsillectomy, don't get your adenoids removed because that will absolutely change your voice. So I think it's interesting, just an interesting sort of addition to the other resonators or the pathway through which we sing and what changes to that. Not only if they literally change, but also how others perceive how they might be changing.
I think that often the trickier part, I think a lot of the data out there shows that I don't think the data is great for the sinus surgeries, but for more of the tonsillectomies, that there's not much change. but there is a change in how the voice feels. So inherently, let's say we measure and there's not necessarily kind of objective changes, but it does feel a little, it does feel a little different. And that's, again, this kind of intersection between science and art and helping the singing teachers and or speech pathologists help them navigating that, yeah, this does feel a little different, but the output is still good, that navigation too.
Yeah, absolutely.
Chloe, this is Alden. I just want to say that was an awesome talk, and I learned a lot. I would love to see some of those slides again later.
Yeah, cool.
And just a little 2 cents. One of my mentors would say, what is the role of a laryngologist, to answer that prior question? And they would cynically say to prescribe a Medrol dose pack.
That is the saddest thing I ever heard, Alden. All right, well, I'm going to close this.
Well done, Chloe. Well done.
Thank you, George.